Welcome to the Health Management Information System. What is health informatics? This lecture I'm going to try to talk just a little bit more frankly. There's going to be text on your note document, so be sure you kind of glance over it. There is a test question in this lecture. And the first couple of reading assignments and lectures you've had have been a little bit more dry, a little bit more about the theory, a little bit more about definitions and some history. And I'm hoping to make this one a little bit more personable. What I do as well as what you all might be interested in when it comes to informatics. More of the fun side of a job of an informatician. So this lecture is going to define the informatics team, skills, roles, and responsibilities, and how health informaticians process data into information and then into knowledge for healthcare tasks with the support of information technology. All of this is a goal to improve patient care. So to begin, we need to understand a little bit about the individuals that are going to be involved with informatics, informatic applications, and the type of work they do. So what is the practice of informatics? According to a report, Training the Next Generation of Informaticians, the practice of informatics most generally requires the presence of two components, a set of skills and methodology tools derived from knowledge of the basic informational and computing sciences. And the second part would be knowledge and experience and activity in one or more application domains. So I've had a lot of people ask me to try to give them like a job description or a skill set to put in a job description when they're trying to hire somebody for the role of an informatician or a clinical informatics analyst. And the reality is it's hard to put a list together because informatics, clinical informatics, informaticians, biomedical informatics, all of those sort of have a broad definition. There isn't the organizations, the professional organizations like ANIA Caring or AMIA or AHIMA, they all deal with informatics and all have different variations of what the skill sets and scopes of the job may be that one does with that title of a clinical informatics analyst or an informatician. So what I can say is in my experience, I have done everything from unjam labels in a label printer to programming in HTML. I've been responsible for server backup tapes and changing them to upgrading the servers. I've managed securities, run SQL and Crystal reports, anything that a person in the world of IT healthcare, and informatics or data collection, storage, retrieval, and dissemination of knowledge could possibly do. The short list that I tell somebody just from my experience that will cover the wide variety would include these applications or skills. The first would be any reporting skills or the ability to use Microsoft Excel or Microsoft Office applications or any open source application that's a variety of spreadsheets or documents. Second would be problem solving and critical thinking, particularly outside the box critical thinking. Think about Apollo 13 type. How do you fit a round tube into a square filter, or vice versa, a square filter into a round filter hole? Preferably have experience in a clinical setting. That may be either an actual clinician, nurse or pharmacist, a tech, a therapist, but it could be even a ward secretary or a HUC, health unit coordinator is HUC, that might have exposure to a clinical environment. And lastly, good communication skills, which may or may not be secondary to life experience, and I'll explain a little bit about each of these. So reporting in Excel. There have been studies done that are showing that despite the use of computers to complete coursework, nursing students and physicians are still graduating with very basic computer skills. You'll hear the term consumers of technology versus users. Consumers of technology download information, they can play on apps on their phone, they use GUIs or graphical user interfaces to manipulate applications like a Facebook page or a web page, but they aren't really at the technical level of the programming, and they use and play with the stuff, but they don't really know how to utilize those applications. The use of Excel and spreadsheets, concatenating data, pivot tables, graphing the data, or being able to add or remove rows and columns can be very challenging for somebody that's not used to working in a spreadsheet environment. This is the world that I have lived in for many years. Almost everything I do involves a spreadsheet in one form or another. You can only imagine when you see data in columns or in rows. Think of flat table files in a database. You need to be able to sort those, rearrange them, graph that data. Oftentimes, I'm even retrieving data from multiple sources where I need to take the data from either a PDF or a text file, and I need to run it through a scrubber so I can get the data into usable chunks or fields that I can then either export into a spreadsheet format or copy and paste into a spreadsheet format, and possibly even do further manipulation to get it to be usable data. How that translates into the worlds of my customers is change control documents that I use to communicate with the customer when they're testing some of the stuff that I build, test scripts that I provide the customer, even the designing of some of the rules and templates and reports that I design, all are based in a spreadsheet format, and the customers and I have to be able to communicate using these documents. If there are challenges with using a spreadsheet, it can almost bring my project to a halt. Problem solving, outside the box thinking. So oftentimes these applications or environments that we are working with have limitations. An example I can provide is provider order entry. Some of you may have heard the term computerized provider order entry or computerized physician order entry, CPOE. This Meaningful Use 1 and Meaningful Use 2 laid the groundwork for requiring providers to use computerized order entry systems and have further passed that into e-prescribing or electronically writing prescriptions. Despite that, there still haven't been strict guidelines on physicians' documentation using templated, codified, discrete data documentation. Many still dictate. Many still will just free text and type a note. And so if we are in a system where as an analyst or an informatician, you're trying to extract data, you're trying to find data points that may be useful in a rule. So you're running a query during the patient's stay that's looking at their allergies, or you're running a query to find out if they have a diagnosis of stroke. And if you find that data element, then you can write rules and other bits of logic that can send alerts to physicians, that can send emails or pages to different clinicians or other users, potentially be used for clinical decision support. And you'll hear me talk about clinical decision support a little bit more. But if they're not documenting, how do we get that information? So one of the out-of-the-box ways we can do that is orders. Many applications have ways where you can create dummy orders, hidden orders. Because one order is placed, you can have another order automatically fire in conjunction that's a hidden order. And using that order event allows the system to be triggered to then do other things like evaluate for the need for an alert or send an email, bring up a pop-up. And so thinking outside of the box, we don't have documentation. Instead of trying to read a free text entry or have some kind of OCR technology, optical technology that can read through text and find keywords, we can actually force keywords to be documented with the use of an order, and it would all happen in the background where the end user themselves never has to click any additional checkboxes. Experience in a clinical setting. So when I talk about clinical experience, there has been an old statement that's often repeated that says it's easier to teach a clinician about computers than it is to teach a computer professional about medicine. And for what it's worth, I can agree for the most part. That doesn't mean you can't learn it. And there's terms and terminology that non-clinical folks can learn and pick up when they're in that environment. And that's why I stress I would much rather have a 22-year-old, radiology technician, new grad, that worked as a CNA in the hospital setting or was potentially the scheduling clerk in the radiology department while they were attending school, than maybe a nurse that's been a nurse for 25 years but works in the rehab department, and that's the only department they ever worked in. And the reason being is that environment, in the radiology department, there's radiology terms that are very unique. There's the flow of patients that are very unique. There is processes that happen between scheduling, registration, notification, mammography letters that need to be sent every 6 months and annually, things of the nature that somebody that has worked in scheduling or even as a secretary in radiology may be much more suited to helping optimize a radiology application than a nurse who's never been in that environment, simply because the nurse is clinical, if that makes sense. Other experiences in a clinical setting would be, again, that flow of procedures and understanding the workings of a hospital or the workings of a physician's office, and how you can improve workflows, how you can improve the use of the application by being able to extract relevant data, make that data useful, and also configure applications and even hardware in order to help improve efficiencies in an area. And finally is good communication. So back to our 22-year-old radiology tech. Communication, when I say life experience, doesn't mean it has to be age life experience. It doesn't mean that a 40-year-old applicant and a 22-year-old applicant, that the 40-year-old is going to potentially be more qualified. What I'm talking about with life experience has to do with conflict, communication conflict, being able to say the same thing several different ways. And sometimes that simply comes with exposure and experience to a variety of situations rather than time or rather than training or particular schooling. So the 22-year-old radiology tech that's a new grad who worked as a waitress may be better suited than a 22-year-old new grad nurse whose only work experience is babysitting the neighbor's kids, if that makes any sense. That waitress probably works shift work. They're familiar with shift work. They're familiar with grumpy people, with nice people, with hungry people, with rude people. People that no matter what they do, the food is never going to be right, versus the person that's so grateful just to have anybody pay attention to them at all or get any food at all. That's the environment of healthcare. You're going to have sick people, people under duress, people that are scared, people that are uncertain, people that are afraid they can't pay. people that think they're being judged for their lifestyle choice or, life choices, as well as coworkers in those same situations. And you need to be able to effectively communicate. And we've got some more lectures on effective communication where you have a sender and a message and a receiver. And if the message that is sent is not the message that is received, then your communication has failed and you need to try to resend that message a different way. So again, these informatics need to possess these cognitive skills, and this list here is sort of just describing some areas of knowledge, and there's lots of things that you can read on the slide, and I'm not going to read through all the notes, but I'm going to give you a little background. Computer science specifically is that hardware or software, right? It's the language of the program you're writing, it's the configuration of your shared partitions, it's the way the SAN array is set up, it's your firewalls, it's the type of keyboard, whether it's an ergonomic keyboard or a bio resistant keyboard, infection control keyboard. The clinical science is the knowledge that a clinician brings in, someone like myself that understands the difference between a person with congestive heart failure and their normal oxygen level versus the normal oxygen level for a healthy adult. And being able to make those kinds of clinical decisions and clinical decisions simply based on that whole picture, using clinical science to understand the differences. Basic biomedical science is going to take into consideration more specifically how the body works in the sense of uh, the at the true biology level, which would touch on what I said about congestive heart failure, but it takes it to another level of detail. So how are the ions working, the salts, the potassiums, your electrolytes? How would medication affect those electrolyte balances? Biomedical would be like the clotting factor cascade, which is that level of detail. I can tell you that if I give my patient an anticoagulant, that means that it's going to affect clotting factors and their blood's not going to clot, or it's going to make the cells slippery. I can use lay terms so that clots don't form. But biomedical science is at that biomedical level, that biology level, chemistry level. Cognitive sciences are going to be your thinking sciences. And some of that has to do with, if you think about workflow and processes, most people would be like linear. So if you were creating a template, you would document from the top to the bottom or from the left to the right. You wouldn't want to open a template and have somebody scroll to the bottom to start documentation and then work their way upwards to the top of the screen. That's cognitive science. And how that affects certain patient types when we talk about clinical informatics. Certain patient types, certain patient scenarios, different care environments would have those kinds of different processes in place, different ways of looking at their templates. Bioengineering is using that biomedical and clinical science together for the manufacture of that medication or equipment that's going to be used by the patient. An example would be making a prosthetic that reduces or inhibits the growth of bacteria. Management science is the human science or the psychology. How do you manage change? How do you encourage conformity or encourage the use of technology, sell it to the end user, make it their idea, using that management science to make change non-threatening. And then, of course, epidemiology and statistics. We had examples of that in the very first lecture with the history of HIT with John Snow and Florence Nightingale and William Farr. So in that same article, The Training of the Next Generation, they identified that second component of the practice of informatics as that knowledge experience. And most of these things will speak for themselves. We talked a little about cognitive and human factors. It's the computer human interface that happens, how you physically type on your keyboard versus the actual technology that you're using, and how that typing actually gets input into the system. Data structures, understanding whether it's data structures by nomenclature or how that database is configured, which falls into the database design, how information is going to be retrieved. Are you running reports? Is it going to be displayed graphically? Are you looking at templates that can also have reports run from the data behind the template? One of the words to point out that's not as clear might be ontology or vocabulary. There are a lot of definitions for ontology, but specifically the way it relates to clinical informatics is, or computer science, is a philosophical component. So in computer science, ontology refers to a model for describing the world as it consists in sets, set types, and relationships. So ontology is the philosophical component of your database. So on your team, you may have people from very different backgrounds. When I worked at the hospital, I had folks with computer science degrees, I had network engineers, I had nurses, physical therapists, respiratory therapists, unit clerks, the chief nursing officer, risk management individuals, respiratory therapists, all of them different levels of education, different levels of experience that were all on my team to help design the applications, to make them more fluid, and to help me with the information that I couldn't get myself. So our risk manager is responsible for knowing all the rules of CMS. And when we talk about numerators and denominators for reporting to CMS for some of those meaningful use or core measures, I can't possibly know that that's not my area of expertise. So I'm very reliant on someone like the risk manager to help me when we're designing rules and alerts related to these core measures or meaningful use measures, that we're effectively meeting them, effectively alerting physicians or providing clinical decision support for those based on her expertise with the Centers of Medicaid Services requirements. Respiratory therapy, the flow of their work, being able to design their documentation and their templates that flows the way they need them to, and be able to capture their charges. Nursing doesn't have charges based on their documentation usually. Respiratory therapists very much do. When a respiratory therapist gives a medication, it usually has a companion charge for the delivery of that medication or the device that was used to deliver the medication. Nursing, you give the medication, it's a done deal. Respiratory, you document you gave the med, and you also have to drop a charge with that for the delivery of the med. Those are all things. I'm not a respiratory therapist. I'm very reliant on someone else's expertise to help guide me. All of this relates back to the high-tech goals, which are advancing cost-effective, high-quality care and patient safety. It's all process improvement and how we can work as a team to make that happen. This breakdown is a little bit of the sub-disciplines within informatics, and I'm not going to go through and read these to you. You can certainly read them in your own time, and we've talked a little bit about such things as bioinformatics. This is the bioinformatician. Health informaticians can include bioinformaticians. It's anybody in the realm of health care. The end result is they're all performing duties where they are acquiring or collecting data, they're storing it, they're knowing how to retrieve it, They're understanding the privacy and security around the information that they are exposed to, and they're able to use that information in presentations to support quality improvement initiatives, changes in the workplace, and promote standards of care for improved patient outcomes. This is just a list of some of the things that they might be doing. Helping to design the software for patient care. I gave you just a minute ago a couple examples of respiratory therapy helping me with their processes so I can design the system to drop a charge when they deliver meds without affecting nursing when they deliver medications. Research systems. For clinical research, it might be from just normalizing the database of the research data that's being collected to actually developing some forms for that database so that the information, the data that's being found or realized can easily be entered into that database. The purchase and implementation for information systems. When you go to send out your request for purchase or your RFPs, it might be you as the informatician that's the person that they're coming to asking for your expertise on what system to select. And that goes back to your discussions with your C-suite, the CNIO, the CIO, the CMIO, the CEO, the CFO, and taking into account the cost of what they're purchasing versus the functionality of what they're purchasing. And just because they can afford the biggest, baddest software out there with all the bells and whistles, they come to you and you're like, you know what, from a clinical standpoint, this will do everything. However, it's lacking in its ability to automate the sending of data to the government for regulatory compliance. So therefore, just because you can afford it and it has all the bells and whistles, because you can't send the data to the government, that might be the showstopper in purchasing that application. But your clinicians don't know that. Your CNIO doesn't know that. They're looking at it from the level of, ooh, we're going to make the nurses happy and we're going to make it easy for clinicians and we can get all this information input and we'll have beautiful looking charts. They might be pretty to look at, but if you can't get the data back out of them and you can't send it where you need to go, basically the information becomes useless. Some other environments where an informatician can work. You know, my experience has been in a hospital and I work for a large electronic medical records vendor. But academia, that's what I'm doing right now. I'm teaching. I'm teaching informatics. I'm working to help you all understand that data collection, storage, retrieval from the world of healthcare. Researchers are obviously they're going to be looking to research everything from the latest pharmaceutical to cancer research. It might be research that you might not think is completely medical. There's a nursing professor who did research at St. Pat's related to shift work for nurses and found a 13% decrease in medication errors if the nurses were allowed to take 30 minutes, a full 30-minute break uninterrupted. That means they didn't have their pager, they weren't responsible for their patient, and 30 minutes they went into a quiet place and rested. They didn't have to sleep, they just were uninterrupted for 30 minutes. A 13% decrease in medication errors. That was huge. That's a form of research. Some of the folks that are going to do the healthcare delivery role, we've got some of the obvious ones, right? Physicians, nurses, pharmacists, dentists. Some of you have brought that up. We have an EMT in the class. That's huge. That's a very big healthcare delivery role. The first responder role. They're the first ones on scene, and they're delivering healthcare. We have 911 operators who are trained as EMTs or are trained to deliver certain levels of emergent health care in the sense that they're on the phone talking somebody through the steps for choking or the steps for CPR. They may be walking somebody through, basic first aid, like putting pressure on something that's bleeding. That's a form of healthcare delivery. Some other roles, I want you to expand your idea of those roles for healthcare delivery individuals. What's missing up here: nurse practitioners, respiratory therapists, physical therapists, speech therapists, radiology technicians, dialysis technicians or administrators. Anybody that has any form of healthcare can be considered a healthcare delivery role. Oh, and one thing I wanted to mention when we're talking about some clinical experience and how it could be a secretary that may be the clinical analyst because of their experience in workflow and processes for that department. The demand for these informatics roles is quite large, and that peak demand is medical device companies, software companies, either to sell the product, to train end users on the product, even provide level 1 tech support, potentially even during a big go live, provide some kind of level 1 tech support. And having some background or some exposure, like the secretary might have from the days before computerized order entry, just familiarity with terms. If a physician calls and is trying to enter an order for urinalysis, and you see the order for a UA, which is a urinalysis, lab abbreviation, that's going to benefit you because you're able to easily direct the clinician to order the UA or search for UA versus urinalysis. So anything that you can bring to the table with communication skills, any kind of exposure to healthcare environment is huge when it comes to the job opportunities in a healthcare delivery role. Assessing information and knowledge and the needs of healthcare professionals and patients. Characterizing, evaluating, and refining clinical processes, developing, implementing, and refining clinical decision support systems, and leading to participate in various facets. So this is just touching again. I'm going to talk more in depth about clinical decision support. I really want you to understand this because this is a big part of electronic medical record optimization when we talk about the application. So if you're not familiar with it, clinical decision support, or CDS, is very similar to the pop-up blocker that you get when you're on the internet, or the security certificate warning when you're browsing the internet. You try to go to a web page and the certificate security warning comes up. It's the pop-up that comes up when you go to close an unsaved Word document, and you have a little pop-up that says, do you want to save? Clinical decision support acts that same way. So if your patient has a particular allergy, you as the physician, maybe they're allergic to penicillin, and you as the physician order bicillin. Pop-up comes up and says, are you sure you want to order this medication? Your patients are allergic to penicillin. By the same token, it could be something much more sophisticated where we're looking at all facets of something that says, ooh, this patient had an anticoagulant ordered and they had a radiology for CT brain without scan ordered, and they had an NIH neuro stroke scale assessment done. Send an alert to quality risk management. We think we have a stroke patient, and specific stroke documentation hasn't been done yet, and it's supposed to be done in the first 24 hours of the patient's registration. That's the type of stuff these systems are doing in the background, and then sending out alerts and notifications, potentially automatic placing of orders and other key components to promote the quality and improvement of the outcome of that patient's care. Again, the leading or participating in various facets of the clinical information system is that example I gave you of system with all the bells and whistles, but it can't generate the reports to CMS. and you might be the person that's leading those discussions. Some different domains. This isn't a whole lot different than the other slide. You can read this again yourself and pull out the pieces. The one that's not mentioned on the earlier side is public health informatics. That's your epidemiology type persons. These are the folks that are on the World Health Organization when the flu breaks out, when the bird flu breaks out, when Ebola is breaking out, when you have an outbreak of TB or measles locally here in Missoula. The public health informatics or informaticians are abstracting all that data and trying to set up their response systems, get the information out, and make some educated guesses on how soon maybe certain things would get here. If Seattle has a huge breakout of avian flu, there's actually statistical inferences that can be made about how soon, when the first avian flu is diagnosed and released in Seattle, we can extrapolate how soon we need to get our resources mobile and in place to handle when the breakout may get to our area in Missoula. Is it 2 days? Is it 5 days? Is it a week? Is it 24 hours? That's your public health informatics. Some other professionals would be your health information management professionals. We haven't talked a lot about that, but some of you in your discussions discovered that the HIT positions are actually a health information management professional, HIM, or medical records department, as some of you may know it as an older term. And medical records, which is now being called health information management, really works on that privacy and security. It may be a set of folks like your quality risk managers along with your health information management or HIM department directors, but it also involves your IT department. Sometimes health information management is your analyst, but the actual programmer or the person that's setting up the configuring the application is actually an IT person. In these roles, when we talk about where the role or the person, the actual physical person of the health informatician resides, it runs the same gamut as the responsibilities. Sometimes they're an analyst within the department they reside. They have less IT access and security. They're more like a super user. They make recommendations. They may collect recommendations from staff on how to improve the system. They may have their own recommendations they come up with. They may be in a particular area like ER where they know there's a specific update for the application that's specific to ER that they really would like to have. The IT role, sitting in IT, can't monitor all of that, so it's up to this super user type analyst that sits in the department to notify the IT person, and that's the role I played. They'd notify me, and then I'd go through the specs and figure out and talk with IT. Do we have the server space? When can we take the upgrade? When's the best time? And do all the technical stuff in the background. My opinion is if the role of the informatician resides in the IT department, they're more effective because they generally have greater security access to the servers and other components, report writing, other skill sets from other individuals that they might need to accomplish their goals. The analyst that sits in the department or the super user that sits in the clinical department and is managed by the clinical department they reside in is very useful for understanding workflow and processes, but you can't give everybody all that IT access. It's too hard to manage. It can get kind of squirrely, and it's just not a very effective use of time to have everybody, too many cooks in the kitchen, basically. So in review, the health informatician should possess some cognitive skills, some logical and analytic thinking, have technical understanding of computing environment, awareness of privacy, come from different backgrounds and experiences, levels of education. There's usually a varied assortment of responsibilities with the end goal to transform data into information that's usable, which can translate into knowledge on how to improve processes. Now we're going to switch gears a little bit, and this is going to be your assignment, and it's the workflow process analysis and redesign. And this is something that I'm very passionate about. Most of everything I have ever done, whether it's report writing, to understanding how the data is being input in the first place, it's installing hardware as well as designing a template for data entry, all based on workflow. So your workflow is a process, right? Your assignment is going to be to create a workflow diagram based on some activity that you do, or potentially a friend or family member does. When I talk about workflow, we talk about the steps. And it's the steps to get from the start to the end result you're looking for. Where it gets tricky, particularly when we talk about designing templates and understanding workflow in the healthcare environment, is with any process that somebody has done repeatedly or day to day, they tend to leave out steps. An example would be if I ask you to make like your grandmother's favorite famous spaghetti. You're going to tell me that you boil the noodles in a pan and you put some stuff in a pan and make the sauce, and then when the sauce is done, you ladle it on the noodles. Someone else might say that actually provide the recipe that says, you need these ingredients, and you go from cooking it this long to adding this and to doing that. When it comes to a workflow, though, what the challenge is remembering that the first thing you need to do is make sure you have all the ingredients. The second thing you need is to actually get the pan from wherever it might be, get the pan from under the stove and put it on top of the stove and turn a fire under it. Then comes the recipe. Then the instructions for how long to cook it. The other ingredients that might need to be chopped up, when to add them, and then in parallel unison is the beginning of the water pot to boil. That's getting another pot, filling it half full with water and putting it on the stove. Most people, if you were going to make this recipe you've done over and over again, there's certain things you just automatically do. You get the pot out and you put it on the stove. You don't think about that. When we do workflows in the clinical environment, that's part of the challenge, is getting people to remember all the steps. And so your test question is the importance of following a person around in order to write down their steps, because people tend to become comfortable with their day-to-day processes and forget steps that have become automatic. So the test question has to do with the best way to do a workflow is to follow someone around and write down every step they take or every step they do. In this example, you can see how we're using specific symbols, and I don't want yours to get so complicated that you've got 42 steps to make a peanut butter and jelly sandwich. That's not the point. But I do want you to give it some detail and think about steps that you might take for granted. And I want you to try to use the appropriate symbols as best as you can. Circles are start and ends, or beginning and end symbols. Diamonds are your decision point. And usually some of the other symbols are for data or inputs. So it's a simple diagram. It defines a process, it clarifies the process, it communicates how it works and illustrates a picture. So creating this visual representation instead of just a list of the steps can really help put it into perspective, and I have a couple examples coming up. Here's what your symbols mean, and at the very basic level, any Microsoft Office Word document will let you do flow charting. You've got, if you're familiar with Visio or have access to that program, it does flow charting. Again, this wasn't meant to be complicated. However you can, I don't care if you hand draw it, I don't care if you type it, I don't care if you do it in PowerPoint, Visio, but make it educated in the sense of use the symbols to the best of your knowledge. Be consistent with those symbols. If you use a semicircle to mean something, I don't care that you use a semicircle or a half moon shape, but use it consistently. If that always means stop, then always use it at the stop. I would hope you'd follow the right symbols, but you understand what I'm trying to say. And make sure your arrows go the right way. Particularly with your decision point, you don't want the actual arrow flangey things pointing the wrong direction, or it can be really confusing. So process is this series of actions or operations. And what's unique about this procedure is related to a process. And the procedure are the steps and how they're performed and the activities and actions, operations and tasks around those. Usually process and workflow can get interchanged, but there is a little bit of a distinction. Now what I do in the company I work for, we have an application called Workflow. We always say workflow with a capital W, and that means the application, where workflow little w is the process. That's the description of what the capital W workflow application logic is doing. Process analysis and understanding relationships in the big picture of what you're trying to do a process analysis of is really important, and it's important to define which things can be done parallel versus sequentially. If you recall when I talked about the spaghetti, there's a point when the parallel is when you get the second pot and you start to boil the water for the noodles at the same time the sauce is cooking. Your sequential is getting the pot first and then filling the pot and then simmering the pot, if that makes sense. So sequentials 1, 2, 3, 4, that the steps happen, parallel as they're happening at the same time potentially. And ultimately the goal by this analysis is to improve a current process, whether it's discovering redundancy or rework, lack of efficiency, which could be related to redundancies. But understanding the process elements and the relationships is where you identify your opportunities for improvement. So I have an example. Scheduling. I had an analyst that was the scheduling application analyst who thought in terms of you have a calendar and this is the time you're available from 8 to 5 Monday through Friday. And so 8 to 5 Monday through Friday, that's what you ask the patient. When do you want to come in for your visit? When do you want to schedule your radiology exam? When do you want to schedule your physical therapy? And the patient says, I can come in Monday at noon, and so you put them on the schedule. And then on Monday, everybody comes to work, and everybody knows what they're supposed to do because we know what patients are coming and how they're going to be seen and what they need to be seen for. In this unique world of outpatient therapies that I was dealing with, it's not that cut and dried. they have very specialized therapists with very specialized skill sets depending on the patient's need. So the patient can't be scheduled anytime they want Monday through Friday, 8 to 5, because that very specialized therapist may only be available on Tuesday and Thursday. Well, then the scheduling analyst comes back and says, well, that's fine. We'll put the resources on the schedule so you know exactly when that person's available. That will work, but there still needs to be some fine tuning because that particular skill set that the therapist has is useful to this particular kind of patient. However, an example would be activities of daily living. A stroke patient or a person with issues that are trying to get activities of daily living, like combing their hair, brushing their teeth, may need morning therapies to help them get ready for the day. And that might be a 2-hour process, where another patient that's being scheduled for ADLs may need help doing laundry or preparing a meal, which happens later in the day, where another patient who's being scheduled for ADLs may need help filling out tax forms or a resume or job skills. It might only take a half an hour. So the bigger picture was understanding the dynamic needs of the patients as well as the available resources and when those resources could be available, and trying to mesh this. It's not something that the schedule could just be recurring and set to be Monday through Friday, 8 to 5. Another example, which takes back to communication, and I'm going to read a little monologue to you of what happened when I went in to do a workflow. I used a wipe off board with my different colored markers and all my circles and symbols, right, and my arrows, and we were going to figure out how this appointment gets made. So the therapist tells me, we screen the patients and then we make an appointment. I said to the therapist, who is the we that's making the appointment? Is it you, the therapist, calling the provider or the patient and actually putting something on the calendar, or is it the secretary? The therapist says, the secretary. And I say, okay, you just said that you, the therapist, called the patient. So are you calling the patient and then the secretary is calling them back? And the therapist says, no. The secretary calls the patient and sets up the very first appointment. I got the eraser and erased the wipe-off board, and we started all over again. So that's a point of communication where the therapist is using the word we make the appointment, meaning the facility versus the therapist versus the secretary, when I'm trying to uniquely identify all the steps. And in this next slide, you're going to see this flow of work, what the steps are, and whose tasks it are to complete some of these steps. In this case, it's the therapist's task to do the screening, but they can't screen the patient until the secretary makes the appointment. And then after the therapist has screened them, the therapist has to let the secretary know what kind of appointment to make, and then the secretary works with the patient to make the appointment. It gets very confusing and sometimes too many middlemen, but you need to understand the tasks, the data, and the people that are all involved to make that whole process from start to finish flow. Once you can get those elements and the relationships between them, then you can identify opportunities for improvement. And a lot of times writing it out on paper, or there's another process I was involved in where they actually had big sheets of paper on the wall and colored string, believe it or not. And the string was the connecting the dots from here to there, the different steps to where the next step in the process would be. And And what's unique about something like that is sometimes people don't realize literally the spider web of steps that they're doing and how inefficient it is that they're going back and forth and back and forth. We're going to have another lecture coming up, if you didn't read it already, where we talk about infection control for surgery. And the idea is that all these patients were getting sick during surgery. They had a checklist. They came up with a checklist. All of these things needed to be done in a certain to be done in order to prevent infection. You first had to wash your hands, and then you had to put on your sterile gown and do all these steps. But it didn't really affect the incidence of infection. And so somebody, like I said should be done, somebody followed the physicians around as they were preparing to put in these central line type surgical procedure to put in a central line. And when the person, the analyst, followed the physician around, they found out that the place where the physician washes their hands is at the end of the hall. And then they have to go 50 feet in the other direction, and behind a closed door is the cart that has their supplies on it. And they have to move that cart to wherever the patient's room is. And the end result was there wasn't anything all in one place. They had to go several steps in 8 different places to get all the supplies they needed. And they end up putting one designated place the cart was always stored, and the cart has all of the supplies on it that they need. And so they can go get the cart, then wash their hands and get gowned up and go into the room, and the incidence of infection goes way down. And that's in another lecture. But that's that process of following them around to see just how much work they're doing. Due to time, I'm going to try to get through some of this a little bit quicker, but know that data is just data until it becomes information. You have to have a qualifier. If I say the number 98 for vital signs, you don't know if that's 98 degrees. You don't know if that's a pulse that's 98. You don't know if it's the bottom number of a blood pressure. So giving data meaning and making it information and turning it into knowledge is being able to attach a description to it. So as an informatician, when you're running those reports, you need to make sure you bring in your qualifiers. What is that 98? The 98 is the temperature. The 98 is the pulse. Then that data has meaning. A pulse rate of 98 versus a blood pressure of 98 can be very different. This is just data and information flow. I'm going to let you read through this. There's some old terminology. What used to be data flow is now information flow. Back to our original history of IT, where they were saying 98,000 people die was due to good people in a bad system. The HITECH Act is trying to get good people in a good system. And how can we do that? We need to understand the processes and relationships, identify opportunities for improvement, understand how tasks are accomplished, by who accomplishes them, the order in which they accomplish them in, and a task priority. Task priority would be the difference between designing a template for vital signs in an ambulatory care setting versus designing a vital sign template or workflow process in an ICU. In an ambulatory care setting, you may get 1, maybe 2 sets of vital signs. And it doesn't really matter how many screens you have to go to get there, because it's just something that the nurse or the healthcare assistant is doing while the physician visits with the patient. Maybe they write them on a piece of paper, put them in their pocket, and enter it later. In an ICU or during procedural sedation, you need vitals every 5 minutes. You can't click on 6 different screens to enter those vital signs, and it might even be a priority that that unit gets monitors that automatically transmit the data directly into the electronic medical record. That's prioritization. Information needs need to be identified. Who needs the information? When do they need the information? How soon do they need the information? And where does the information need to go once you have it? So whether that's being able to extract it from the record directly, or whether that's extracting data elements and compiling it into a report that can be given to somebody. Some unique healthcare requirements. Patient care is centric. It involves a team of people. Everything that we're doing in HIT is trying to coordinate patient care between all the different disciplines. The reasons for e-prescribing are so that everybody's medications can be and allergies are readily available in crisis situations, to prevent polypharmacy. The continuity of care document is so that from one physician to another, from one specialist to another, your primary care to your heart specialist, everyone is working off the same information about you as the patient. That's your patient-centric. Every situation is unique. I've described to you multiple scenarios during this lecture of different types of situations where there's overlaps of roles and responsibilities, where there's changing priorities, where unique situations have to be identified and accommodated. So pulling it all together, a clinical informatics analyst, an informatician, a clinical analyst, a super user, an IT analyst, their roles are going to vary. It's more than just medicine that benefits from this. It can work in all forms of work. I mean, law enforcement, medical, business process management is all of a factor when it comes to informatician. Related to health IT, again, any of these experiences you can take from a healthcare related area or your health IT certificate is going to make you more valuable because there's a high demand right now for these types of people. Some common issues and change control that we have. You can read through that. Again, it's very detailed, and I apologize the lecture's so long. Once you have a process identified and you have a workflow that you've mapped out and you're ready to improve that process and you map out the improvement, you need an implementation plan. And that plan is going to help you execute the improvement that you're going to make, whether that's starting with your change control on your template or your findings on your template, to educating the staff before the template is in use, to any other downstream effect changes, like changes that will be need to made to reports that get sent out for quality measures. There's very many facets, and this implementation plan will save you heartache later downstream after you've made your change if you have it in place. These are the components of your implementation plan. I'll let you read through those. Again, the notes themselves have quite a bit of text on them. And part of involving when we talk about workflow and following somebody around is you really want to involve them in the process. Give them some ownership. If the end user has ownership, if they were part of the decision making on how that template's going to look in the end or how that report's going to display to them in the end, how the alert or the clinical decision pop-up is going to appear and be useful, they're going to be more accepting of the change. And this little Chinese proverb, tell me and I'll forget, show me I may remember, involve me and I'll understand. And that's really the key to any successful change management, workflow improvement, process improvement, is involving the stakeholders that are going to be affected by that change. These are just some takeaways on what they need to know. Again, I apologize, it's been a long lecture. Why the change is happening, involve them. If they're involved, they will understand and be more accepting of the change. You can have checklists, talking points. Cheat sheets are really good if the change is significant, and I'm sure some of you that experienced some of the Cerner or Epic Go Lives at Community and St. Pat's and were involved saw some of these processes taking place, the cheat sheets and the checklist, talking points, the training that had to go into it, and the different forms of training. I had a consultant who used to say 7 times 7 ways. They had visual displays in the form of a running looping video. They also had static paper displays hung up in the walls. They had them at key locations like above garbage cans or above the water cooler where people would gather and stand around and have time to read. The back of the bathroom door is infamously known as the best place to put any kind of communication because that's what you're going to look at while you're going to the bathroom. So 7 times 7 ways the information is communicated about the change, because chances are one of those ways, everyone will understand one of those ways, at least one way that it's communicated. So in summary, it was a huge lecture. I apologize sincerely that I wished I was in a classroom with you and we could have a great discussion about all these things. It's something I'm so passionate about. But the summary is they need cognitive skills and logical thinking. You've got to have experience, life experience, communication experience, have some computer awareness and experience. All of your teammates will come from these different backgrounds. There's going to be multiple assortment of responsibilities, but the end result is transforming this data into information in a secure fashion, in a usable fashion, so that it can then be disseminated as knowledge for process improvement. Workflow summary, the way that work progresses, it's a coordinated process, usually follows a sequence or organized process. It's so you can identify areas for improvement by mapping it out in a visual format to put it into perspective. Healthcare workflow tends to be more unique and complex than other business type workflows. Everyone learns differently, everyone communicates differently, so use a variety of communication skills and training aids and those different theories from the management, like the psychology of change that we talked about earlier in this lecture. Thank you so much, and I'm so sorry it was a long lecture, and don't hesitate to email me if you have any questions.